Good afternoon, everyone. Glad to be here in New York City. Thank you, panelists, for choosing our case for presentation. Can you hear me now? In December 2022, 40-year-old male with a 10-year history of psoriasis started receiving IL-23 inhibitor therapy for psoriatic arthritis. Soon, 2 to 3 months after, patient started experiencing progressive symptoms, including night sweats, and 6 months into the therapy, patient noticed a painless, non-mobile lump on the right side of the neck. On imaging, CT scans showed bulky right cervical lymphadenopathy, with PET scans showing hypermetabolic lymph node conglomerate with SUV of 18.8. Excisional biopsy showed partially preserved architecture and scattered HRS cell, predominantly in the interfollicular region. IHC showed characteristic phenotype for Hodgkin lymphoma, including weak FAX5, strong MUM1, and Golgi pattern CD30. Also CD20, 79, and CD200 positive as suggested in this study. EBV by in situ hybridization is positive along with strong LMP1, while ABNAP2 is negative, indicating EBV latency pattern 2. As you see, EBV was mainly positive in HRS cells, not any B cell or immunoblast, excluding polymorphic LPD with HRS-like cells. Chromosomal microarray analysis did not detect any genomic imbalances, while NGS detected tier 2 splice site variant in ATR gene with allele frequency of 57%, possibly germline variant. With this proposed diagnosis, classic Hodgkin lymphoma, EBV positive, possibly iatrogenic or related to IL-23 inhibitor therapy. Before we discuss tumor microenvironment of this case, we'd like to briefly review this pathogenesis of psoriasis, which involves hyperactivation of Th17 pathway via IL-23 and IL-17 axis activation, which releases IL-23 and IL-17 interleukin. IL-23 is key cytokine, while IL-17 is an effector downstream, maintaining Th17 cell expansion. With IL-23 inhibitor act on P19 subunit of interleukin 23 and continue and combine IL-12 and 23 inhibitor act on P40 subunit, which is shared with interleukin 12. And IL-17 inhibitors inhibit IL-17 and its receptor downstream to IL-23. So far, largest study involving 100,000 patients established psoriasis as an independent risk factor for Hodgkin lymphoma, and this patient had 10-year history. So far, only one case is reported of Hodgkin lymphoma with patient receiving IL-23 and IL-12 inhibitor therapy. Most of the recent meta-analysis and systematic review reported no increase of relative risk of Hodgkin lymphoma, with the caveat being that this risk was with comparison to TNF inhibitor therapy. And most recent integrated clinical trial analysis of 11 trials receiving guselkumab did not report any increased risk of lymphoma, but there was extensive study showing 2 unspecified lymphoma. It is important to note that usually tumor microenvironment of EBV Hodgkin shows Th1 profile, while EBV negative lymphoma shows Th17 profile. Soon after the diagnosis, IL-23 inhibitor was withdrawn, but 2 to 3 weeks after, patient received 2 cycles of ABVD regimen due to large size mass and repeated syncope episode, and it showed complete response. To understand the immunomodulatory effect of this IL-23 inhibitor, we conducted tumor microenvironment study using this COMET platform, which is based on sequential immunofluorescence, in which for each marker there was sequential short incubation by primary antibody followed by fluorophore tagged secondary antibody to end the cycle with the elution step. And after each cycle, image was captured and cycle was repeated to render the final composite of all 9 markers we used. Amongst night marker we use TBEC, which is transcription factor for the Th1 cells. CCR6 chemokine receptor we use to identify Th17 cells, while CCR4 we use to identify Th2 as well as Th17 cells. We'll review the result of each marker. As you see here, CD4 in yellow shows predominance of CD4 positive T cell, while TBEC positive T cells are rare. Whatever nuclear positivity you see here, those are actually positive in HRS cell, which you look in the closer shows also CD20 co-expression DIM, membranous DIM co-expression of CD20. But again, TBEC positive T cells are rare. This is in B cell, HRS cell, which is reported in the past. We validated further by IHC. CCR6, which is marker for Th17 pathway, shows co-expression with the B cell. And CCR6 positive Th17 T cells are rare. This is in the B cell. Additionally, we validated using IL-23 receptor. As you see, there is a depletion of Th17 cells. This is CCR4 in blue color, a marker both for Th17 as well as Th2. It does not co-express with Th17 marker, which is CCR6, indicating dominance of Th2 cells. We validated further with CCR4 and also validated with GATA3, which was showing similar result. CD163 in magenta color shows relative lack of M2 suppressor macrophages, which is also should be more abundant in Hodgkin. Immune checkpoint CTLF4 in purple color shows numerous immunosuppressive T cells. And this is the final composite with all 9 markers. In summary, we have a paucity of Th1 cells shown by only few TBEC positive T cells, indicating possible loss of anti-tumor protective effect. We have paucity of Th17 cell and showing rare CCR6 positive or CCR6 positive with CCR4 combination. It's showing loss of anti-protective effect against virus, because this case is EBV positive. And we have predominance of Th2 cell, which indicates there is a reprogramming of Th17 cell to Th2 effector cell. There is no mechanistic link established yet, but this is in contrast to usual Th1 profile reported in this study. In conclusion, therapy for psoriasis with IL-23 inhibitor has most likely promoted reprogramming of immune system from Th17 to Th2 response, permitting the development of EBV positive classic Hodgkin lymphoma. With final diagnosis, classic Hodgkin lymphoma, EBV positive, likely iatrogenic after immunomodulator therapy. The panelists asked 3 questions. I'm covering the first one. First question was regarding spatial proteomic platforms currently available. We have this major 6. Out of that, nanostring and 10 times genomics also target RNA in addition to protein. These are another 5, which Maxima imaging and Virzan are more in use. Integration of this spatial proteomic platform is challenging, but that is across all platforms. But this clinical integration in the clinical workflow, these are 4 major phenocycler fusion, nanostring, comet, and 10 times genomic has more potential and being attempted recently. With this, PhenoCycler has the fastest spatial biology system with highest throughput, while NanoString has the most comprehensive platform, including since it captures not proteomics but also transcriptomic data. But 10 times genomics is cost effective because it has downstream NGS analysis included. Second question was how this IL-23 inhibition reprograms. As you see, we do not have Th1 cells. There's depletion of that. We have paucity of Th17 cell because of the inhibition of through IL-23. The only pathway left was Th2 programming. So ideally, due to Th17 cell or plasticity, due to plasticity of Th17 cell, it can polarize towards Th1 or Th2. But Th1 cells we don't have, so we assume that the inhibition led Th17 cell polarize towards Th2. And with the last question was classic Hodgkin lymphoma in the setting of PTLD and also in non-PTLD setting. In both settings, the Hodgkin lymphoma shows positivity for EBER in 80 to 100% cases. But withdrawal of the immunosuppressive therapy is more effective in PTLD setting than in non-PTLD setting. In first-line therapy for in PTLD setting is reduction of immunosuppression, means withdrawal of therapy, and plus rituximab and chemotherapy. But still, their relapse risk is 17 to 27%. While in non-PTLD setting, withdrawal doesn't work most of the time, especially Hodgkin lymphoma behaves more aggressively like in PTLD setting. So chemotherapy and radiation is usually required, and with that, relapse is low, but still data is not out there yet enough to conclude generalized enough. These are the major studies. On the left side, you see post-transplant in immunosuppression complication in EBV positive Hodgkin, published recently in February 25. And the right side, we have Dr. Moriro's 10 cases in Hodgkin lymphoma in iatrogenic setting. With that, I would like to thank my team, especially Janush, who helped me with this study, and my mentors, Dr. Nejati and Dr. Vasik, for their constant support and supervision throughout this project. Thank you.
Thank you very much. This was a very clear presentation and beautiful images.
Thank you.
Does anybody have a question for Dr. Shah? Well, sounds like it was exceptionally clear. So, thank you very much.
Thank you.
And